So they're saving the best for last. So basically, I'm going to talk about hand numbness today. Generally, over the next 15 minutes, or maybe a few minutes more, we're going to talk about anatomy, pathophysiology, diagnosis and treatment, and mostly I'll talk about peripheral neuropathy, which is what I deal with the most, and this is mostly compressive neuropathies. And this is dealing with radial sensory neuropathy, cubital tunnel, which is the ulnar nerve, and carpal tunnel, which affects the median nerve. So causes of hand numbness can come from a lot of different places. As talked about before, it can come from compression of the cervical nerve roots that come out of the neck. It can also be from trauma or stretch injuries to certain nerves. So like this injury is more of a traction injury from on the brachial plexus, and that can cause a significant injury and numbness in the hand. But in addition to that, there's also lacerations to nerves, contusion injuries that can cause the numbness. Chemotherapeutics and HIV medications can also cause some peripheral neuropathy. And then, of course, diabetes, which causes a polyneuropathy. This usually affects the feet first and then the hands. I'm not going to talk about any of that stuff. So, innervation in the hand. So the sensation in the hand mostly comes from three nerves. The most common or most well-known one is the median nerve, and that's going to give you sensation along the palmar side of the hand and the radial side of the hand. On the ulnar side of the hand, that's going to be the ulnar nerve. And then on the dorsal side or the thumb side, that's going to be more the radial nerve. So I'm going to focus on these nerves that cause numbness. Neuron. This is a neuron. So neuron consists of a cell body and kind of projections from that. There's going to be the dendrites as well as the axon. The axon is what's responsible for sending nerve signals and also responsible for supplying the nutrition to the nerve itself. So a bundle of neurons then form a fascicle. Bundles of fascicles are then joined together, and that's what creates the peripheral nerve. So the bundles of fascicles are surrounded by endoneurium, and then those bundles kind of create this peripheral nerve. It's all protected by the connective tissue that really protects it. And so this is the endoneurium around the fascicle, the perineurium in between, and then followed by the epineurium around it. And so that's really helps to protect the nerve. So the pathophysiology of compression neuropathy is kind of listed here. It starts with pressure on the nerve. And what that does, it doesn't actually injure the nerve. What it actually does is it decreases the blood supply to the nerve. And that ischemia then causes some edema within the nerve. This blocks basically the axon from being able to transmit any of the nutrients and also send any of the nerve signal. So ultimately, this leads to axon or nerve demyelination and remyelination, which can cause degeneration of the axon and then ultimately fibrosis. So these compressive neuropathies are not actually an inflammatory process. It's a fibrotic problem. So diagnosis of compressive neuropathies, it's really kind of the same as diagnosing anything. The most important part is the history and physical. So you really want to get an idea from the patient, when did it start, what makes it better, what makes it worse, what do you associate it with, does it happen at night, does it happen when you're driving? So, that really helps kind of differentiate which type of neuropathy it is, and also location of where they're having the numbness and tingling in the hand. In terms of sensory testing, there's some shown here. So the threshold test is using a filament to try to see when the patient can actually feel it. So the thinner the filament is, the better their sensation is. And then if you have to go to a larger filament before they can actually feel it, that's a sign that they are getting the neuropathy. Density test really is a measure of how many nerves are in that area that they can feel. So it's a 2-point discrimination test where the thinner the 2 points are, the better your sensation is. And as that 2-point, if you have to go really wide for them to actually feel 2 different points, that's a sign of progressive neuropathy as well. In the office, we do provocative testing. So we're basically trying to recreate the compression to see if they develop those symptoms again. And then if the history and the physical exam isn't really conclusive, then there's nerve testing as well. So the nerve testing, there's really 2 parts of it. One is the nerve conduction velocity testing, and the other part is electromyography. So the nerve conduction is really to get an idea of how quickly is the nerve sending signal, how quickly is it receiving the signal, and the electromyography is really looking at the muscles to see, is the muscle being affected by the nerve being compressed. Once you see effects on the muscle, it's fairly progressive. And the EMG is actually good for differentiating also between cervical radiculopathy as well as peripheral neuropathy. Treatment for these neuropathies is similar as treatment for anything. You start with non-operative things first. So rest, activity modification, or changing how you're doing things. Anti-inflammatories can help certain conditions. Splinting, as seen here. So the top one is wrist splint, which can help with carpal tunnel symptoms. The middle picture there is an elbow splint, which can be worn at night to help some of the cubital tunnel symptoms. And then ultimately, if nothing conservatively is working, then we move on to surgery. So I'll start with radial sensory neuropathy. This is actually pretty rare. So the incidence is 0.003%. The radial nerve starts from C6, 7, and 8, become the brachial plexus, and then it's a continuation of the posterior cord of the plexus. So this then, the radial nerve branches into the PIN, or posterior interosseous nerve, which is more the motor nerve, as well as the sensory, or the superficial branch of the radial nerve, which is the sensory part of it. So the sensory branch then becomes more superficial in the forearm between, if you can see there, the ECRL, or extensor carpi radialis longus, as well as the fascia from the brachioradialis. So the causes of neuropathy in this area is usually direct pressure on it. So the times that I've actually seen it in the office is prisoners who have handcuffs on that are too tight, or restraints. And so that external pressure actually causes the nerve to not send the signal out as well. Another cause is actually inflammation in the tendons and muscles. So at that internal kind of pressure on the nerve can also cause these symptoms. And then traction on the nerve as well. So the symptoms, again, that's going to be the numbness and tingling kind of on the back side of the hand, affecting the thumb side. And it gets worse when if there's pressure on it from either handcuffs, tight bracelets, tight watches. So treatment, similar to treatment for everything again. First, you want to remove the inciting incident. So take off the handcuffs, take off the bracelets, the tight watch, rest, changing how you're doing things, anti-inflammatories. And here the anti-inflammatories are to try to decrease the inflammation in those muscles and tendons. Splinting and padding may work. Most of these cases resolve on their own and don't need surgery, which is good because the surgery is not as effective as we would like. So luckily, it gets better on its own. So moving on to the ulnar neuropathy, this has a slightly increased incidence with 0.025. The ulnar nerve is a continuation of C8 and T1 from the neck, and that also goes into the brachial plexus and is a continuation of the medial cord. The ulnar nerve then travels down the arm and goes into the cubital tunnel. So the cubital tunnel is the area that we described in the medial part of your elbow, and this is the space between your medial epicondyle and your olecranon. So the nerve goes through the space, it then dives between the heads of the flexor carpi ulnaris, and then is in between the superficial and deep finger flexors. About 5 centimeters proximal to the wrist. It gives off a sensory branch to the dorsal ulnar part of the hand, and then the rest of the nerve dives into Guillaume's canal in the palm. And there it gives sensation to the ring finger and the small finger, and also gives you some motor function to some of the muscles in the hand. So symptoms from cubital tunnel are listed here. So it's going to be the numbness and tingling in that ring and small finger. Some people will have pain in the medial elbow. The symptoms are worse when you hyperflex the elbow. And the reason for that is because you're putting more traction on that nerve. A lot of people will have night symptoms, and this is because a lot of people will sleep with their arms curled up. And then as it progresses and it starts affecting the intrinsic muscles, then you start getting some clumsiness and weakness in the hand. So on exam, this picture kind of depicts a severe case because you will notice atrophy within those intrinsic muscles. And you see it mostly in that first web space between the thumb and the index finger where they've really lost the muscle there. Wartensburg sign is when the pinky is kind of held out and they can't bring it back in. And the reason for that is because that nerve innervates the muscle that helps bring it in, and actually it's a different muscle that pulls the finger out. Froment sign is if you have a piece of paper, you ask them to try to pull it out. If they can't pinch it with their fingers flat and they have to actually kind of bend their fingers, that's a sign of ulnar neuropathy as well. So when they actually bend the joints to hold the piece of paper, they're using a different nerve. A positive elbow flexion test. So if you hold your wrist in a hyperflexed position for a long time, and then you start developing numbness and tingling in those fingers, and then a Chanel at that medial elbow. So if you hit kind of that cubital tunnel and you feel a zing into your fingers, that can be a sign of cubital tunnel as well. So the treatments for this, this top picture shows a splint that you can wear at night, and it basically just helps prevent you from bending your elbows at night, hopefully, relieving the symptoms at night so you can sleep through the night. Padded elbow splints during the day, and that's mostly to relieve the pressure on the elbow if you're resting it on certain surfaces, and then just trying to limit the amount of flexion that you're doing in the elbow. In terms of surgery, most of these are treated with in situ decompression. There's a lot of other transpositions, but what they found is most people just need the decompression in that area, so we just open up that space. So the most common cause of hand numbness that I see and probably everyone sees is carpal tunnel. So carpal tunnel is a median neuropathy. The median nerve, the incidence is 0.1 to 10%, although I don't know, I feel like it's a lot more than that. So this nerve is from branches of C6, 7, 8, T1, and sometimes it's C5 as well. These nerve roots, again, go through the brachial plexus, and it's a continuation of the medial and the lateral cords that form the median nerve. This goes down the arm. It then branches off into the AIN, which is more of a motor branch, and the rest of the median nerve courses through the arm. It goes between the pronator teres, underneath the pronator, between the superficial and deep finger flexors, and then 5 centimeters proximal to the wrist. There's a palmar cutaneous branch, which gives you some sensation to the palm there, and the rest of it goes into the carpal tunnel. This depicts the carpal tunnel. The carpal tunnel, basically the way that it's made, it's actually in the proximal palm. A lot of people feel like it's in their distal forearm, but it's actually in the hand itself. So the proximal palm is where your carpal tunnel is. What makes up the carpal tunnel, the bones in the wrist are actually the floor of the tunnel. Within the carpal tunnel are all the flexors that bend your fingers down and your median nerve. At the top of the carpal tunnel is the transverse carpal ligament, which really forms the roof of that tunnel. So it's this enclosed space. A lot of the associated factors with carpal tunnel syndrome are shown here: obesity, hypothyroidism, diabetes, pregnancy. And with pregnancy, a lot of women say that it goes away after they deliver, but typically it's a sign that later in life you're probably going to have it. Kidney disease, inflammatory arthritis, and trauma such as distal radius fractures. Other factors associated with carpal tunnel, so in the past they always said it was typing. It's not typing. Typing doesn't cause carpal tunnel. It's actually mouthing. So using the mouse on the computer can increase your risk for carpal tunnel. Another factor is occupational factors, so repetitive work or assembly line work, as well as vibrating tools such as jackhammers, motorcycle riding, again, because of the vibration mostly and the gripping the whole time. That increases your risk for carpal tunnel. And then again, repetitive activity. So the symptoms from carpal tunnel, usually it starts off at night as night symptoms. People will wake up in the middle of the night, their hand will feel numb, they feel like they have to shake it out or change position before they get that sensation back. But it's numbness and tingling. So it's mostly in that volar radial part of your hand, but a lot of people can't differentiate that in the middle of the night and they feel like it's their entire hand. As it progresses, you can develop difficulty with fine motor skills and weakness in your grasp. Pain is not necessarily carpal tunnel. So if you have just pain in your hand or wrist, that's not going to be the carpal tunnel. But if you do have pain associated with the burn, if it's burning pain associated with numbness and tingling, that can be carpal tunnel. And a lot of patients complain that it feels like their hand's swollen even though it's not. So in terms of severe carpal tunnel, this is shown here. When it's very severe, there's a compression on a motor branch to that thumb muscle. And so you'll notice in the hands that there's a lot of flattening or loss of muscle in that thenar eminence. So office tests for carpal tunnel are shown here. So Tinel test is really tapping on the carpal tunnel to see if that causes a zing into your fingers, and that's a sign. Phalen's is a top picture here, and that's really hyperflexion of the wrist. And what that does is it increases the pressure in the carpal tunnel. So if that causes symptoms, then it's, suggestive carpal tunnel. The most sensitive test is actually the compression test. So if you just hold pressure over the carpal tunnel, and typically we hold for at least 30 seconds. And if by holding there and putting additional pressure in the carpal tunnel, if you develop numbness and tingling there, that's a pretty good sign that you do have carpal tunnel. If the physical and the exam isn't really conclusive, then I do refer patients for nerve testing. But, in the literature, it does show that there's a false positive and false negative rate with these nerve tests to 10 to 15%. So treatment for carpal tunnel syndrome, especially with mild symptoms, we always start conservatively. And that typically starts with activity modification, which means trying to limit the amount of wrist flexion or extension in the wrist. Splinting can help. Anti-inflammatories. So the anti-inflammatories, ibuprofen, Aleve, they're actually not to treat the nerve itself because it's not a problem with the inflammation in the nerve, but it's fibrosis. So the anti-inflammatories, what it can do though, is decrease inflammation within the carpal tunnel itself, thereby giving the nerve some more room. Night splints are mostly to prevent you from curling up too much at night so that you can hopefully sleep through the night. And then cortisone injections can be both diagnostic and therapeutic. So if you give an injection into the carpal tunnel and their symptoms get better, that's a good sign that it's carpal tunnel. And then the problem with the injection is just that it's transient. It's not a permanent solution. So it can give you some relief, but it's not going to last forever. So ultimately, there is surgery. So with surgery, Blazer at Brigham did a study, and they went through all the papers and found that the success rate was approximately 72 to 90%. So another thing with the surgery is that the correlation of your outcomes aren't based on how long you've had the symptoms or how old you are. It's really based on how severe the symptoms are. So if you have constant numbness in your hands, difficulty using them, it's waking you up every night, even if that's a short period of time, that's more indicative that you need surgery sooner than if you've had, intermittent symptoms. Every once in a while, my hand goes numb for 50 years. And then with the surgery, there is a reoperation rate of less than 5% though. So in patients who are old that have really severe symptoms, they have constant numbness in their hands, and they have thenar atrophy, it's been shown that they still do get relief with the surgery. So, most people have improvement in symptoms, but that's not complete relief. So typically they won't get all their sensation back, but they're usually satisfied with the outcome as long as they know what to expect. And if you did nerve testing on them, what you notice is that the objective numbers actually do improve. So with revision carpal tunnel releases, I'm always reluctant to do it because it's about 50-50. So half the patients will get better, half the patients will have no change. So bottom line, sensation in the hand from 3 main peripheral nerves: radial nerve, median nerve, the ulnar nerve. The most common cause of hand numbness that I see is going to be carpal tunnel. The diagnosis of this is basically on history and physical exam more than anything else, but you can also do diagnostic testing as well. And the treatment for any of these neuropathies, non-operative or operative, is really to take pressure off that nerve. Thanks.